Dear audience, dear chair, in the next 10 upcoming minutes, I would like to present to you my PhD thesis, which is titled is Mechanical and Optical Properties of Enamel and Dentin. My name is Peter. I'm an MD PhD student from Department of Prosthodontics. My vision with my PhD work is to help to define dental aesthetics with the academic language of science, and my mission in that is to specify what natural looking means scientifically. And for the sake of this goal, I would like to present to you my two ongoing projects. Both of them uses the methodology of systematic review and meta-analysis. The first one is an investigation of the effect of teeth whitening on enamel structure, which is a comparison of in vitro studies. Based on the different published surveys, we can define tendencies among patients regarding their dental aesthetic satisfaction. I'm almost 100% positive that these tendencies are not only true for patients, but for you as well. Based on these, almost all of you in this room hide your teeth while smiling because you're displeased with your current dental appearance. More importantly, almost 60% of you are unsatisfied with your current tooth color. What can you do in this situation? Tooth whitening. Why? Because it's easy, cost-effective. But as with every procedure, tooth whitening also has its flaws. Most of the in vitro studies report reduction in the organic and mineral component, which results in the reduction of microhardness. So my aim is to determine this change of microhardness and to offer the safest concentrations and time to do this treatment. Which leads to my clinical question: how do different teeth whitening methods will influence the microhardness of human enamel in vitro? My outcome is microhardness, which is measured by Vickers microhardness number or Knoop microhardness number. My hypothesis is that tooth whitening will decrease the microhardness of human enamel. On this slide, you can see my systematic search, and after completing each step, I was left with 144 eligible full text. Before showing you the results, I would like to give you a brief review on how these experiments are carried out, because it will be important to understand my forest plots. After the extraction of teeth, the root portion are cut off. Then we create enamel slabs and embed them in acrylic resin. After that, there is a microhardness measurement, which is a baseline measurement, and it will be termed as before bleaching microhardness value. After that, we do the bleaching, hopefully according to the manufacturer's instruction. And when we're done with bleaching, we have another microhardness measurement, and it will be termed as after bleaching microhardness value. Although it seems nice, there are many factors changing during the experiments. For the better understanding, I've grouped them in two. The first one is dealing with the bleaching agent. Obviously, the concentration and the time of these materials changing among papers. The other is a bigger issue, and that is the indentation. The type of indenter, the load of indentation, and the time of it differs. That is why, for the preliminary results, we fixed it. We only included those studies that use Knoop indenter with 55-gram load for 5 seconds. Based on the concentration and time, we created subsets and subgroups. On this slide, you can see how we divided them. The first two is containing low concentrations of hydrogen peroxide used for a longer period of time, which is commonly true for at-home bleaching when the patient can bring home the product and do the bleaching for themselves. We created two subsets because the currently available European guideline does not allow nor patients nor dental practitioners to use any bleaching product that contains more hydrogen peroxide than 6%. The third group or subset is dealing with high concentrations of hydrogen peroxide for shorter periods of time, which is commonly true for in-office bleaching when the tooth whitening is carried out by a dental professional. At the end of each row, you can see the number of articles that are included on the forest plots. Let's see the results. What is microhardness? Microhardness is the ability of the human enamel to withstand the different forces in the oral cavity. If the microhardness is low, that means the enamel is weakened. Giving you exact numbers of these microhardness values wouldn't be so informative. That's why I've decided that we've decided to create a percentage value. That percentage value is the ratio of means. That is a calculated number from the before bleaching and then after bleaching microhardness value. If the value is, for example, 90%, That means that the microhardness is decreased from the baseline 100 value to the 90% value because of the bleaching. Our opinion is that 20% reduction in the microhardness can be termed as clinically significant. If we see the first subsets and the first subgroup result, we can see that doing the bleaching treatment with low concentrations for 2 or 3 weeks will not cause any clinically or statistically significant damage. However, continuing this experiment for approximately 6 weeks will cause clinically and statistically significant damage. It was investigated by one author, but this author included in his study products where the concentration and the usage time was similar, but different products were used. If we look at moderate concentrations, we can see that 2 to 3 weeks usage does not cause any change. Using them for 6 weeks, however, significant damage. If we continue to in-office bleaching, we can see that only in the subgroup where it was used for more than 90 minutes could we experience clinically and statistically significant damage. The strengths and limitations. The strengths of this study is the large sample size that we included in-office and at-home bleaching. We investigated human enamel, and we included Vickers and Kloop measurements, which is not true for the previous meta-analyses. The limitation. We used the sum of bleaching time. Of course, we have different concentrations and different time, and unfortunately, there is a protocol deviation, which basically means that some authors decided that they do not follow the manufacturer's instructions during the bleaching treatment. They reportedly or unreportedly overused the product, which would shape the results in an unwanted direction. That is why we will exclude those articles. What is the conclusion? After 3 weeks of at-home bleaching and over 90 minutes use of in-office bleaching, significantly decreases the microhardness of human enamel. What is the implication? The implication for practice is that bleaching procedure should be carried out according to the manufacturer's instruction. If we're dealing with patients that want to do at-home bleaching, we should warn them that they shouldn't use this product more than 3 weeks. If we carry out in-office bleaching, it shouldn't be more than 90 minutes. What is the implication for research? Obviously, the standardization of measuring methods in contact with the indentation type, the load, and the time. Our opinion is that the effect of pH should be investigated more carefully because it can be a connection with the microhardness decrease. On this slide, you can see my flow chart, and I would like to jump to my second topic, which is evaluation of the effectiveness, safety, and satisfaction of teeth whitening in vivo. The background is quite similar. Most of you are still unsatisfied with your current tooth color. Most of you still want to treat it by tooth whitening, but the biggest flowback reported in vivo is tooth sensitivity. The reported prevalence can even hit the 93% among patients. So what I can tell you is that with a very high chance, this drawback will occur. However, I cannot tell you how much you will benefit from the treatment. That leads to my clinical question. What is the benefit of tooth whitening in terms of effectiveness, safety, and satisfaction? Effectiveness is measured by shade difference. Safety measured through visual analog scale, which is a scale from 1 to 10, where 1 is when you can experience no pain, no sensitivity. 10 is when you're in severe pain. And satisfaction is completed through a survey how the patients were satisfied with their treatment. Our clinical implication is to determine the cost-benefit of teeth whitening. Our hypothesis is that the effectiveness is low compared to the our hypothesis is that the effectiveness is low compared to the occurrences complications. On this slide, you can see my summary of my 2 projects, and I would like to thank you for your attention with a quote from the famous dentist Stephen Bergen. Color may be unimportant to the physiologic success of a restoration, but it could be a deciding factor in the patient's acceptance. Thank you so much.
I have a question regarding your first topic. In your plots, the first subset, you had a 42 days you had the same author, I believe, maybe because there are different brands or something that happened. But I noticed that the value was much lower. The before bleaching value was much lower than the other groups. So what was the reason behind this, and how do you think this could impact your results?
Thank you so much for the question. Yes, your impression was very good. We have issues regarding with this paper because we thought that maybe in some sort of switch in the experiment, or maybe a statistical analysis lead to significantly lower values of microhardness. However, after reviewing the paper, I did not find anything. That is why I've decided to contact the authors. Unfortunately, I did not receive any information so far.
Okay, maybe you could consider maybe removing that one. I'm not sure.
Yes.
Because there's such a huge difference between the before bleaching value that this could impact the results.
Yes,
So, maybe just take a look at this. Thank you.
Thank you.
Do you have any idea how they have defined the 6% hydrogen peroxide for the current guideline?
Yes, thank you so much. Unfortunately, most of these studies used bovine teeth, not human teeth, and they were in vitro studies. This was the lowest concentration where they could not find any significant damage in the microhardness of human enamel, and for safety reasons, they've decided to include this in the current guideline.
What do you think about the remineralization? Because in the mouse, there is a phenomenon maybe with the fluoride or maybe from the saliva.
Yes.
What do you think?
Yes, these are in vitro studies where they placed in artificial saliva, where the concentration of calcium and phosphorus is almost the same. I think it can impact the results, and our hope is to define that how much time should pass to state that the microhardness is rebuilt completely to the baseline value. Unfortunately, these studies does not have such a follow-up period, but we will see if there is enough data to tell anything about that.
How do you plan to compare them? Because microhardness from microhardness differs.
Yes. Currently, there is an available. So we plan to contact physicists because there is a currently available conversion table from each measurement, and we plan to use those conversion table to make it more standardized.
How can be the color changing measured?
It is, unfortunately, there are very different ways to measure. We have in the clinics available shade tabs, and we can compare the shade of each teeth. If they match, they're good. If they don't, then it's sad. But we can use these shade tabs, and we can also use spectrophotometers, which is more precise because it can give us exact values.
Do you have any plan about how are you going to evaluate or measure the satisfaction of the patients?
So these are measured through different surveys. The patients answered different questions from 1 to 10 or 1 to 5. How satisfied are they with the results of the bleaching, in terms of if they can sense any pain, if it become whiter enough for them. So that is how.